14:05. I think we start, and I will share a case that has puzzled us slightly of this 68-year-old woman with what appears to be a couple of hepatic cysts in the left liver. I stop here this image, and I will start, I will share with the other so that you can see. Can you see? Can you see this?
Yes.
Yeah.
Yes.
So this is the CT scan that appeared to us. The MRI that was shown to us. You see a big cyst in the left liver and a smaller cyst more central. What attracted our attention is this dilatation of the bile ducts here. Otherwise, the patient had an ultrasound because of vague abdominal nothing, completely normal liver function tests. She's a lean, fit lady with the only problem is slight osteoporosis. But otherwise, and the hepatologist asked us, what shall we do about this liver cyst? Shall we do anything? Because she's completely asymptomatic. And then we asked her about the gamma GT and the alk phos. They were normal. They repeated them. They were normal. And then we started munching about it and reviewing a bit of the literature. And I would like to ask the people around here what they would do for this patient. Surendra, can you give us some advice? Maybe we leave you for the end because you are the most experienced.
No.
So Manuel or Angelica or somebody else, can you give us some advice? Or Sylvia?
The cholangiogram or a MRI, cholangio MRI?
The MRI is the best, in fact, the best way to see them is this one, because otherwise on the cholangiogram, on the reconstructions, you see the cyst and you see virtually nothing else. But this is
there a connection
fairly...
between the bile duct and the cyst? So
no,
direct...
absolutely not.
No? Okay.
Absolutely not.
Our practice when we have what we think that and it seems like a benign and cyst, serous cyst. When we have the dilatation of the bile duct, we assume that about the compression of the cyst, and we used to perform the fenestration. We only perform the fenestration in two situations: the symptomatics, or if we have a dilatation of the bile duct to prevent further complications of the bile duct obstruction.
So in your unit, you decompress the bile ducts, even if the patient has no symptoms and
even if
liver
there's
tests
no
are
cyst.
normal.
Yeah, we perform the fenestration of the cyst.
Right. Do you try to, beforehand, to know whether this is a normal cyst or whether it is a cystadenoma?
If we have worrisome features, yes. If the cyst seems to be a serous cyst, we don't. But if we have a thickness in the wall or enhancing wall, then yes. And in this case, we don't perform the fenestration, but the resection.
Right. But in this case, there are apparently, at least on this technique, no other signs of it being atypical. Bonjour, Monsieur Bismuth. Here we are with you.
I just, Pietro, you listen to me?
Yes.
You listen, I just arrived. I have just arrived.
But
30
to
seconds.
make it
So I
short
see
for
only
you,
the image. I don't know what is the case.
yes, it's a 68-year-old lady, completely fit, no symptoms, ultrasound done because she was sent by her GP just for a screening ultrasound. And liver function tests are completely normal. But the ultrasound found 2 big liver cysts and slight dilatation of the bile ducts in the left lobe. Liver tests are completely normal. ALK, PHOS, gamma GT, completely normal. And we were asked, is this a simple cyst? And shall we decompress the cyst because it's compressing the bile ducts? So these are the 2 questions. And I show you the picture as well.
You know, I told you sometimes I have a patient like this one, a young lady with a cyst discovered totally by hazard, fortuitously, and they have some symptom, but the symptom was strange, not at all in relation with something in the liver, like a colopathy. And then in this case, I do a puncture and I evacuate the cyst in order to see if there is relation with the cyst and the symptom. And it seems very easy to do it. Of course, it is not a treatment, but it is a diagnostic. So what I may propose in this case, if I understand well the
Yes,
case.
I agree, monsieur. But this patient has no symptoms whatsoever, so I cannot do it to have the disappearance of symptoms. She has none.
No, but you know, she has not symptom, but sign. No symptom, but sign. The cholesterol, the dilatation of the bile duct is a sign, not a symptom.
Yes. But should I treat this patient simply for a sign?
Okay, but if you evacuate the cyst and you see that the bile duct recover the size, at that time there is a compression by the cyst.
I know there is a compression by the cyst because I can see it. I know it already.
At that time, you have to treat the cyst. For a compression by the cyst with time.
Even if the patient has no symptoms.
But this is a sign. It is a sign.
Right.
I mean, the dilatation of the bile duct, I don't see that. But the dilatation, I don't see the picture. The picture is very small. The left branch. Okay. I think with time, it will give stones. There is stasis. If there is dilatation, it is stasis in the bile duct. And the stasis will give a formation of stones. And at that time, there will be a symptom or atrophy of the left lobe. It is so easy to treat the cyst.
This is, yes, any other?
Pietro, you are right to say there is no symptom. But when I say this is cyst, this is sign, we treat the sign, not the symptom.
Yes.
But you are right to say no symptom. But sometimes we discover, for example, you do ultrasound in a patient without symptom for something else and discover a nodule in the liver. You have to treat it, even if it is no symptom.
Right. And any other advice? Tim Public has published extensively in general, but also on cysts. Tim, what would you do for this patient who has?
Yes.
Have you seen the pictures?
Yeah, I saw the pictures, so I've been kind of in and out. No, it's an interesting case because, you know, it looks like a normal, like simple cyst to me. I mean, I don't think there's any mural nodularity. There's no enhancing of the wall. There's no septations. The only thing that's a little bit weird, obviously, is the biliary dilatation, you know, but, you know, it's asymptomatic. So, I appreciate what Professor Bismuth is saying. You know, I don't know about aspirating, because to your point, if she doesn't have symptoms, you know, aspirating it, I'm not, you know, it's not going to resolve her symptoms, so she doesn't have symptoms. I mean, I think I'd be inclined to, you know, probably do a laparoscopic cyst fenestration of it. And then, you know, basically then we'd have tissue diagnosis and we could see what the wall looks like, you know, and if it is just bland and truly is a simple cyst. I think the, you know, that's relatively straightforward. I mean, the patient can go home the same day. And I think that's what I would offer. It's in a favorable location to be easy to do. And then we would definitively know what it is. And, you know, since there is some biliary ductal dilatation, presumably from mass effect of the cyst, it may help alleviate that also. So that's probably what I would offer. And I would caution
Right.
her that if the cyst wall came back, that it was something more suspicious, then she might need to go back for a more definitive operation. Although I suspect this is just going to be a simple cyst, but I could be wrong.
Now, Surendra.
Yeah. So by and large, I agree that it looks like a simple cyst, but when you're talking about the biliary dilatation, okay, how are we ruling out a communication with the biliary tree? Is it a biliary cystadenoma? Does this cyst contains bile or not? So will you like to do a HIDA scan to show that if you see the activity within the cyst, that means it is communicating with the biliary tree? And in that case, will you do just fenestration or will you go for excision?
Yeah, I think that's a good
Yeah.
point, actually, because if it does communicate with the biliary tree and then you do a cyst fenestration, then it's going to result in a biliary
But I mean,
leak. So
it's
I think your
exceptional
point is
that
well
this
taken.
is, yeah. But
What were you going to
Surendra,
say?
it is absolutely exceptional that they communicate with the biliary tree, isn't it?
Yeah.
Yeah, but then see that sometimes actually a few months back, I came across a patient where it was like a biliary cyst intrahepatic in segment 4B, okay? And we found it communicating with the right hepatic duct. We didn't know how to classify that. It was solitary cyst and it, of course, it contained the stone, so it was easy to diagnose that way. So here, yeah, there is no evidence, but if you find on table while doing fenestration there's a bile, what will you do?
Yeah, but in this case, you are starting to shake all my knowledge, which I thought had increased by preparing this case. But in this case, a puncture simply of the cysts would allow you to measure the bilirubin inside and show you that the bilirubin is not normal. Now, if all the comments have gone, I will stop sharing this and I will share my presentation and see what I learned on preparing the case. And this is it. Can you see?
Case? What is the conclusion of the case?
No, it's not concluded yet. I will present what I've learned and then we discuss on the basis of what I learned. And then I will suggest my conclusions. We don't have many cases, so we have a bit of time. Here are the liver function tests of the patient. And on the differentiation of simple hepatic cysts versus cystadenomas, I found two papers which were, or three papers which are particularly helpful. This one by a group of North Carolina, they analyzed the very simple cysts, the cysts with that are opposed, and in which you can see a septum with a dent, and these are generally the benign cysts, and this is the septum of a cyst adenoma that does not indent the wall, and this is a thickened septum. And simply by looking at these features, the authors found that, in fact, they had a positive predictive value of 90 to 100% in operating the cystadenomas and sparing the unnecessary surgery of patients with simple cysts. So this then, in fact, is something we have to look in simple cysts that are opposed with a septum, and septum without the dent, which is more typical of cystadenomas. This is a sign I did not know, and I think contributes to the difference. The other thing which worried in particular for my case is this paper by Kim and others, who analyzed the radiologies of cystadenomas and simple cysts. And they found, as Gilles Monta used to say, that normally cystadenomas are solitary. And if you see patients with several cysts in the liver, the atypical cyst is generally not a cystadenoma. However, cystadenomas liver cysts are frequent between 2 and 10% of the population. So 2 and 10% of the population will have also liver cysts. But the two signs that they found important were the upstream dilatation of the bile ducts, which we have in this case, and the transient hepatic attenuation difference, the TAD in the liver, which we don't have here because we can't see it because it's an MRI and not a CT scan. And the author in this paper, which is an older paper, I think 2005 or something, they say that MRI alone is not enough. You have to have MRI and a focused ultrasound and a CT if you have the doubt, because this is where you analyze better the features and the septum. And the third paper, which I found, which Laurent Chiche mentioned in her talk, was analysis of the intercystic fluid, which I heard talking about in the paper, but in practice, I don't know whether anybody of you does that. But this is very, very telling. These are the tumor-associated glycoprotein, also known as CA72.4. And in this study by Olivier Farge, published on the BGS about 10 years ago, they found a very good discriminating potential for this marker. And these are the values I translated from the paper to make it more readable. These are typical cystadenomas with a higher value. The cutoff that he establishes is 25 international units per milliliter. And these are atypical cysts with the values of the glycoprotein. And on the following slide, again, which is even more worrying, the atypical cystadenoma with none of the Wardigan features. Inside, they had the values of this glycoprotein, 11,000 for this one, which I would have tagged as a simple cyst. This one and this one, they all had higher values, whilst the typical cyst had a lower value. And on the paper, this is a logarithmic scale, the value of the glycoprotein. There is some overlap, but in fact, being a logarithmic, the distribution of the marker in the cyst is much, much higher and can help you discriminate. And this is for CA and CA19-9, which are not useful on the function, whilst the tag is useful. And on this basis, on the basis of this, I quit my presentation, and I would take it as a worrisome feature. If we can talk about worrisome features for biliary cysts, the fact that this patient has a dilatation of the bile ducts, I would puncture the cyst and send the fluid for the glycoprotein to be measured. I don't know in France who does that, but clearly Laurent Chiche talked about that and Olivier Farge talked about that. I will see whether there is any bilirubin, which is exceptional And if there is a doubt, I think we'll operate the patient. If there is none and the patient has no symptoms, I wanted your advice. If this is a simple cyst with a dilatation, I take your advice, Monsieur Bismuth, and it was Sylvia who said that we should operate the patient nonetheless. But of course, it's a different operation if we find that it is a cystadenoma beforehand, which I think is useful information to have. So my conclusion is, after preparing this case, puncture, dosage of the glycoprotein, and then on the basis of that, probably surgery, but it's two different surgeries that we would do.
In any case, you will treat the cyst. And you say the technique is different. Of course, it is a tumor or a banal usual cyst, what you said. But what could we do if it is a tumoral cyst? What would be the treatment?
Well, it would be excision of the cyst, or possibly a left hepatectomy with excision of the cyst. I haven't looked exactly at the vascular anatomy yet of this patient, but I think you can treat cystadenomas by simple excision. And I think I would go for that, but I need to a better imaging to decide on that.
Okay, but you agree to treat the cyst in any
Yes.
case.
Yeah,
I agree for that. I come back. I am sorry if we have a little time to speak about when I said at the beginning. So you say there is no symptom, and this is correct. There is no symptom, but I say but there are signs. But in tumor in the liver, we are very pleased to discover the tumor when there is no symptom, which is usually, fortunately today, we discover when there is no symptom. It's a pity to have symptom. It was in the old case, I remember at the beginning of my experience with a tumor, the tumor was symptomatic. Large tumor with jaundice, pain is terrible. So fortunately, we discover without symptom. That means that today is better to discover the sign and not the symptom, which is the case of this patient. This is why I say, anyway, if there is dilatation, there is compression, and we have to do surgery. And the question is, what type of surgery? And you are right. It depends of the nature of the cyst. I have the feeling, according to what you said, it is two cysts, no? That means, according to you said also, there are more chance it is benign.
I agree, but it's rare to see benign cysts that induce bile duct dilatation. And so the red light came up.
If you do the puncture, you do the puncture of the two cysts. Pietro.
Yes.
Yes. At that time, I may recommend to evacuate the cyst. At that time, you will see if there is dilatation, if the regression of the. For if after evacuation, the dilatation remains exactly the same, this is indication to do a liver resection. For there is a stricture.
Yes, I see your point. Thank you.
I think. Okay.
And I also use the test of evacuating the cyst to understand whether the symptoms are due to the cyst or to other non-specific abdominal condition. I think that's
Yes.
extremely useful. And I ask the patient to keep a diary of the symptoms. I tell them they will reappear probably. If it's a cyst, they will disappear and they appear between 2 to 4 weeks and they come back, in which case we either operate or ethanol injection to the cyst.
You know, I saw many times this circumstance. You know, people experience some pain in the abdomen. Now, ultrasound is always performed. That means if we consider the frequency of the cysts, you discover around in 4% of the cases cysts. And automatically the cyst is accused to be the cause of the symptom. And this is not the case. Sometimes the symptom is not at all a symptom of the liver disease. This is why I do the biopsy, I do the puncture, and often the symptom persists after evacuation of the cyst. That means we have the proof. Sometimes it is colopathy or gastropathy, and not at all something. And the sign is benign and without symptom and no sign. At that time, there is no indication to treat the cyst. If not, if you treat the cyst and the symptom persists, I call that the post-cystectomy symptom. You know,
Yes.
like post-cholecystectomy syndrome.
Yeah.
When you
Right.
treat the
So
disease, when you treat the disease, which is not the cause, it is a post-disease syndrome.
yes.
Okay.
Right. Thank you very much for the advice. We have a second case, and Alessandra is presenting the second case.
Hello, good morning, everyone. Can you hear?
Yes, it's nice.
Okay, just a second. Can you see the presentation?
Yes.
Okay, so our second case is a young man who comes from Afghanistan. Actually, he is a refugee and he has been traveling since the last 2 years through many countries before arriving in Switzerland, where he is now for 3 months, and he's staying in an asylum center. About 2 weeks ago, he had an acute pain and a syncope, for which he was brought to the emergency room of a local hospital in another part of Ticino, not our hospital. So he is in good health, no past medical history, no previous operation, and this is the first time he experienced such a pain. He refers to have an intermittent fever and shivering since a few months, 5-6 months. And he has lost some weight, but this is also, we think, in the traveling that he has done through the last years. And he has a post-traumatic distress, which is treated. So when he arrives, he has normal vital parameters, a tenderness at the abdominal examination, and a completely normal laboratory, except for azatenalate and a slight inflammatory syndrome with a CRP of 27. And they perform an US finding some free fluid and an X-ray, which is normal, no pleural effusion. And this is the CT scan that is performed. So it's quite evident, a very big cyst in the left liver with septum and free fluid in the abdomen. The septa are taking contrast in haste. there is probably a mild dilatation of the bile duct, but the bilirubin is normal. So actually, the team that was in charge at that moment, they functioned the ascites, they performed a paracentesis. It was a cloudy liquid with some nucleated cells, mostly neutrophils. There were very a few eosinophils. They performed bacteriology, hepatitis serology, EHB serology, and TBC on serology on the liquid, serology for echinococcosis in the blood, and also a PCR in the abdominal liquid. And these are the results. So no TBC was found, no hepatitis, no HIV, and no bacteria through infection, but a positive Echinococcus granulosus on the serology and on the liquid. So actually they completed with an MRI. We weren't aware of this case at this moment. We were called afterwards. So this is the T2. The free fluid is getting better. The MRI was performed about 5 days after the CT scan. The clinic of the patient was better. He didn't develop peritonitis, and he was stable, and the pain got better. And this is the hepatospecific phase. Actually, we cannot see any left bile duct. I will show it again. So after this workup, he started albendazole, and we were called. So this patient comes from an endemic area, and he traveled through also endemic areas. The host, the main hosts are dogs and sheep, and actually he was a shepherd in his country, so he had contact with these animals. And according to the World Health Organization, the classification of this sedatic cyst is the CE2, which is an active phase, developing daughter cyst from the proligerate membrane inside the main cyst. The intraperitoneal rupture is a quite rare complication compared to biliary fistulas. But actually in this patient, the risk could be an anaphylactic shock that likely he didn't develop. So actually we have this patient, the cyst is very big. We have a documented rupture. The PCR on fluid was positive, possibly a covered rupture, as the clinic got well very quickly and spontaneously. And actually the patient is dismissed. We have a possible bile duct communication, as probably he had some episode of cholangitis with this recurrent fever and shivering, and we don't see any left bile duct. There are no other localization. He had staging with thoracic and cerebral imaging that didn't show any other localization that the liver. And as I said, he started the albendazole since 1 week now. And when we were called, actually, we were thinking to perform 4 weeks of albendazole before treating him surgically. Then we have a few questions to discuss here. Probably we were called at the moment of the major pain, I think an emergency surgery could be considered in the reason of the rupture, intraperitoneal rupture. Then we can discuss actually if it would be better to perform a conservative surgery with a marsupialization, but that carries a very high risk of biliary fistula, as we think there is a biliary communication, rather than a pericystectomy on a left hemiapatectomy. And due to the intraperitoneal rupture, as in a few reports, the peritoneal irrigation with colloidal agents is suggested. Which kind of product would you recommend? And afterwards, how long this patient should continue the albendazole? So in literature and from international recommendation, it can be varying from 1 year to few months. This is the wider review that I found, which is now quite dated. But actually, the median duration of albendazole after surgery was about 3 to 6 months. So the discussion is open.
Alessandra, thank you for the presentation of the case. I think you have all elements to have the diagnosis. You don't doubt about the diagnosis. In addition, you was a shepherd in a country where there are sheep. That means, you have everything for the diagnosis, even the serology and so on. So you said you don't see the left branch of the bile duct, but did you see the left liver?
No, it does not left liver.
I think unless the left lobe, segment 2 and 3, are absent. That means there is atrophy. By compression, it would be a long compression of the branch and atrophy of the left lobe of the left liver. I don't know. I think you have to, of course, you have to do surgery. The surgery in this kind of cyst, when the cyst arrive just at the contact of the confluence, which apparently could be the case, must be at this point conservative. That means no cystectomy at the contact of the confluence. This is a catastrophe, as you know. That means you have to do a radical left hepatectomy, which is automatically made when you do the cystectomy and you arrive at the hilum, and then you let the cyst there. You cannot remove it, as you know, and you have to say that for the young one that assists to the meeting now, that the cyst is not the parasite. The cyst is the structure of the liver, of everything which is around. It is a reaction of the liver. That means cystectomy is a partial liver resection. You agree for that? You understand what I say?
Yeah.
Yeah.
The danger in this case, when the cyst arrive at the contact, the confluence from above, when you approach from above, is to be very careful not to continue the cystectomy at the level. If not, you may remove. I observe some case of that, which is the most severe biliary trauma. The biliary trauma due to resection of echinococcosis cyst. It is terrible. I think, Pietro, you have this experience, perhaps, and we should be very careful in the treatment. So I think in this case, you have albendazole. I am not expert in the length of duration of the albendazole treatment before surgery. I don't know, but if you say 4 weeks, I don't know. People say that longer is albendazole treatment. If it is efficient, it is better. But I have no. You know that how long must be the preoperative treatment by albendazole? 4 weeks is enough.
4 weeks, to my knowledge, is what is recommended for the hidatic cyst.
Okay, at that time is good.
Yeah, we had a very good presentation, and we will ask the advice of our colleagues from Argentina, who have a huge experience on that, much more than us. So we wanted to discuss the case with them today, but they could not connect, and we will submit the case to them. But we'll do a conservative surgery, as they showed in their very nice presentation at the Congress in Uganda.
Can I say something?
Yeah.
Prashant here. Hi, Pietro. Hi, Alessandro.
Hi.
Good evening. Sorry, I just joined, just finished LDLT and just joined on a Saturday. So, so some few questions that Alessandra had posed, maybe I could respond to how we follow it over here. In terms of treatment, duration of treatment, we would normally prefer somewhere close to 8 weeks. This is a complicated sort of hydatid cyst because it has ruptured. It's a complicated cyst of echinococcus granulosus. So there has been a partial rupture of this and you've drained this. So there is some degree of peritoneal contamination. So it would be nice to treat this for a period of about 8 weeks before actually going inside. The second thing is that, what do you do intraoperatively when you have to open it? What is the type of solution that we use? So we use concentrated povidone iodine here. So you use sponges which are soaked in concentrated povidone iodine and put them all around the liver. Because like you rightly mentioned, the main problem here is anaphylaxis. So if there has already been, and probably the response that he had, where he had a sudden shock along with the free fluid, was because of some degree of anaphylaxis that did occur because of the rupture of this particular cyst. So what you need to do is put those betadine sponges, which are soaked betadine sponges, around the entire area where you're planning to open that cyst. And before you actually open it, we use a simple technique. You use the laparoscopic trocar attached to maybe the end of the, a suction tubing, initially to inject concentrated povidone iodine, and then you can aspirate it along with the, aspirate it through that suction before you actually open up that cyst. So it is like what they have done, even radiologically, what they do in the pair technique, you actually try to do that in the during your surgery itself. And then you have a controlled opening of that particular cyst. So that is something that will help you for sure, so that there is no spillage outside during that particular period. As regards how long will you continue it, I think that generally we've had the tendency to continue it for a period of 6 months to 1 year. And if it's a complicated one which has ruptured, I would continue it for a period of 1 year. I would continue the albendazole for a period of 1 year, and that would be a double dose of albendazole. So it will be 400 milligram twice a day that I would continue. So this is in short, I think, to answer some of your questions. One of the easiest diagnoses of this, I know Professor Bismuth told us that, you have everything here for making the diagnosis. Very few people, and I appreciate that they did this, that they did a hydatid serology or they did echinococcus granulosus in the fluid that was selected. One of the easy ways, in fact, is on ultrasound to see the hydatid sand. This is very typical, and even in the you would see daughter cysts on your MR or on your CT scan if your radiologist is well experienced to identify these. So these are typical findings. What is not very typical is enhancement of these loculations. So you can consider them, I think the explanation is the CE2. That means the acute inflammatory phase, why you saw this particular, enhancement. Whenever there is enhancement and there is biliary, you're not able to see bile ducts, your idea or your tendency is more to think of, is this some mucinous cystadenoma or something with communication into the biliary tract, and is it a biliary cystadenoma? So I think the reason for that is basically because there was acute inflammatory stage. Thank you. I think that was long, but thanks. That's our experience and how we have followed it.
Very nice.
Sorry, we have used in previous cases hypersaline solution. Do you think it can also be good?
Yeah, you can use it. You can use hypertonic saline as well inside. But you know what happens is that we've been using this for a long period of time. We've been using concentrated povidone iodine to this thing, or you can use the povidone iodine, concentrated povidone iodine swabs around, sponges around, and you can inject the hypertonic saline, wait for a while, and then suction it using a closed system. Make sure you do it using a closed system so that there is no spillage that is happening.
Okay. Thank you.
Surendra.
Yeah. So by and large, I will agree with what Prashant said just now, except if you go back to the images on the CT or MR,
The city is here.
yeah, you can show the CT itself. Yeah, you stop it. Stop. Okay. So what you see is the whole cyst is packed with multiple daughter cysts. It's not a unilocular cavity. And that's where the evacuation becomes difficult. You have to puncture each and every of them, each one of them with the trocar cannula. Okay, so that is one. So when we do laparoscopically, then you go inside and keep on puncturing each and every daughter cyst, suck away the contents, inject with the scolecidal agent. Now coming to the injection of the scolecidal agent, if there is a biliary communication suspected in a hydrated cyst, it is contraindication to use the scolecidal agent inside the cyst, because that any scolecidal agent can cause sclerosis of the bile duct itself. Okay, so that's the one caveat which is there for injection. About the use, which scolicidal one uses, it is very personal choices. We evolved over a period of time. I've used betadine, I've gone to the silver nitrate or the hypertonic saline. Okay. If you see, there are very few studies. There are some experimental studies which have shown that hypertonic saline and silver nitrate are the best scolicidal agent. Not so much povidone iodine, but it remains as a personal preferences. This betadine advantage when you soak with the swabs and pack it around, if the scoliosis comes out, you can see them on the surface of the mobs. That is the only advantage. I agree with Prashant that you use the big trocar. Usually we have what's called the Palani value trocar cannula system, which is a closed system, which has got a huge suction channel, and you puncture that cyst with that, and then keep on injecting the scolicidal and evacuating it. That is the way. But here, the issue is that it is ruptured, number one. Number two, there is most likely biliary communication is there. Number three, again, if you see the CT scan and MR, and what Professor Bismuth was asking, that has it replaced the whole left liver or left lateral segment? Or is there a functional left liver segment or not? If not that cystectomy will amount to the left hepatectomy. So you again put the CT scan again, let's see whether it has replaced the whole of the left liver.
Maybe we see better on the
MR, yes, you can see on MR. So if you see, there's hardly any left liver parenchyma seen there. So in that case, a total cystectomy, which will amount to the left hepatectomy, will be the treatment of choice. You don't contaminate the field. Yeah.
Anterior and posterior bile duct are there.
Yeah. And mostly it will be communicating with the left hepatic duct. So you'll have to ligate that. So in this case, it is replacing that whole of the left liver.
So the main
Yeah.
hepatic starts there.
Yeah, main confluence is there. See, yeah.
I think the cystectomy should not be done here. I think we should empty the cavity after it has been sterilized, because at cystectomy, there's a very high risk of removing.
Yes, Pedro, I agree with you. Majority of the time, we do conservative evacuations only. But here, there is a biliary communication. If you do that conservative, there will be bile leak. And then you have to close that biliary communication. That means you have to ligate the left arm, because there is no other liver remaining. Ultimately, you have to ligate the left arm.
And with the bile duct communication, we have a higher risk of necrosis of the bile duct using a hypersaline solution in these cases. So in our experience, when we have the suspicion of a bile duct communication, we always perform the resection. We don't open the cyst, we resect. And in this case, I think that the resection is anatomic left hepatectomy.
I'm very worried about the resection, Sylvia here. And I think the whole point of the communication of our Argentinian colleagues is that once you've treated with a bendazole for the 8 weeks that, or the 4 weeks that Prashant and Surendra recommend, in fact, you can be less invasive with the hypertonic saline or the betadine. But we need to, I still haven't clear the kind of resection or cystectomy that this patient needs. I'm very worried that in fact we'll end up with the wall of the cyst being made by the biliary confluent here. And so you try to do a closure of the left duct, but I would be more confident in having emptied the cyst and not resecting it. But we have time to think. We have more time to evaluate this patient, and we may get back to you in planning this hepatectomy with more detail.
Sure.
Actually, in this case, the peritoneal contamination has already happened because it was rupture at the diagnosis. So
Yes.
I don't think it makes much difference if we to strictly avoid contamination during operation or not.
Yes, but it was a few amount of liquid. You have the risk. This is an active cyst. You have the risk of anaphylaxis during the surgery, and that's the danger.
It will be no longer active. It will be killed, the parasite.
It's never 100% kill, Petro. That is the problem. We have not documented 100% versus 50% or 40%. That's difficult. The other thing is that there are multiple of daughter cysts. So if you go for evacuation, you have to evacuate each and everything, because all of them are quite big. They are within the cyst, there are a lot of cysts. So you have to evacuate. Yes, it can make your surgery easy. I can tell you that you do a closed system of evacuation, not the open system, and keep on puncturing and evacuating each and everything. And then at the end, you will have just a loose membrane sort of a thing hanging in your hand, and you can just resect. That can make it easy.
Okay.
Yeah.
Technically, that can be easier.
Yeah. I think we may do for that.
Alessandra, it is not an easy surgery, it is sure. I think when we discuss to open or not to open the cyst, I think that you cannot do a total cystectomy. It is impossible due to the involvement of the structure of the hilus. And that means you have to open, it is sure. So I think that on the right, it is not difficult to do the cystectomy. For you have the parenchyma, you follow the parenchyma. Then approaching the hilus, at that time, you must let, all the structure at the contact of the confluence. And then the question is on the left. And this is the question. And it is not easy. For the left lobe is atrophied. And you cannot let it. At that time, I don't know really. You have to see at surgery what you do. You may do outside of the liver the ligation of the left pedicle, and then from this side go to let the objective at the end is to have nothing on the left liver and almost total cystectomy except a plaque on the islet. I think this is the objective. This is the objective. And this is the security.
And I think I see it exactly as you mentioned.
What?
I see it exactly as you mention it.
Yes.
This is how I had it in mind.
This is the objective. Suandra and Prashant, you had the experience of this kind of this disease. What do you think?
Yeah, so what happens that ultimately on the table you have to modify the things. When the cyst is large, it is difficult to handle it. So we do that. We can use the closed system for evacuation of each and every cyst. So daughter cyst contents are already evacuated completely. So then it becomes flaccid. The whole thing becomes flaccid. So it becomes easy to manipulate or manage. And then you start excising it. Now, we don't want to go into the liver parenchyma. And what actually is, it is a germinal layer which has to come out because that is the cause of recurrence, not the outer layer which is responsible. So in that case, what happens that you end up doing what is called the partial cystectomy. That means what is hanging out, you keep on excising it. What is jutting out of the liver, you leave behind the rim there. Okay. And from inside, when you see that whole germinal epithelium has come out, okay, and then you look for the biliary opening and close it. That is the usual way we do it. Now, here why I was saying the left hepatectomy, because almost I feel that there is no left liver remaining there. It's completely replaced by the cyst. So that is the only reason why I said that it will amount to the left hepatectomy. So ultimately on table, you have to take a final call. You can do laparoscopically. That's fine. But yes, I'm against
I wouldn't do it laparoscopically, honestly.
No, it depends on the personal experience and this thing. It's not necessary to do laparoscopically. We have been doing open also, but it depends on there's a personal philosophy. Those who are well versed with that now, if we ask Daniel Chesky to do it, he will say, yeah, I will do it laparoscopically. So it depends on the individual capabilities and all those on laparoscopy. I'm sure Prashant will say, I will do robotic.
No, I would do this open actually. So I would do it open. I would do a closed suction aspiration and I would do a pericystectomy. A pericystectomy similar to what Dr. Mathur has said. I would not actually go too much into the liver parenchyma. I would, and exactly like Professor Bismuth says, at the hilum, this is the major issue. So once you have, or you go into the bile duct or you go or hamper the bile duct or you injure the bile duct in any way, this is a mess. This can be a real issue. So I would not even go close to the hilum. I would actually remove the cyst wall. Like Dr. Mathur said, in the inside or the layer is what is more important. So I would remove what I can and then make sure that there is no biliary communication anywhere. Unfortunately, even if you have a biliary communication, there's not much you can do here in these particular cases, because there will be very tiny biliary communications here. Once you actually open up that entire anterior wall and you see inside, there may be small communications which are there entering into the wall. And you can't do much about it. So at the most, what I would do is that I would take some momentum and put it in that particular area and cover that particular area. After I've laid open and I've done a pericystectomy. And probably if there is a biliary communication, post-operatively, I may want to do something like a sphincterotomy, so an endoscopic sphincterotomy, so that facilitates the drainage so that there is no further communication over there. But I would be very conservative. I would definitely do this open and I would not actually go for an anatomical hepatectomy in this case.
Yes, I agree, Prashant. I think we must be very cautious in this case, and to have the security. Open is the secure way to do it. I think somebody will say we may do robot, we may do laparoscopy, but to be more secure, it is open, to have the more chance and the more facility that you have. For me, the problem is on the left. Patient, if the left lobe is totally atrophied, is like a large cyst, no, large fibrous wall, you know, with all the structure, of course, inside. What do? You remove the left lobe, totally atrophied, or you let it?
Professor Bismuth, I think it's the same principle that you have kept teaching us about hemangioma. So I will not do an anatomical hepatectomy. I will still try to go just a little rim beyond this particular cyst wall and not really bother whether I'm doing a left hepatectomy or not. I would just want to take care of this cyst wall, open it up, see if there is biliary communication, probably fill up the omentum, and try not to go close to the hilum at all. Because if there is a major communication here, that's what I'm scared of over here with that bile duct being not seen on the left side. So it may amount to almost like a left hepatectomy, but I would stop short and say that, I would do more of a pericystectomy rather than actually doing anatomical hepatectomy.
Prashant, indeed you are right. I think it's better to be very cautious. I agree with you.
Okay.
Well, what qualified advice that we get. Thank you very much.
Thank you, Pietro. Thank you, Pietro. Alessandra.
Right.